and this is, I don't know, my fourth or fifth or maybe more event that I've worked on this year. And I'm excited to end the year with, I think, what's a really exciting topic to kind of go into the new year, considering that we started the year with me moderating a panel with a bunch of research leaders talking about research funding, the week after there was no research funding. So this is a much more positive conversation to have, I think. So we'll dive in. I've got we have three incredible panelists here, two of whom I've known for a long time, one of whom I'm getting to know. And so I'm gonna go alphabetically by last name and do some introductions and kind of give each of them kind of a quick opening salvo, and then we'll dive in. But just one kind of fact that I was reminding them yesterday is I'm thrilled to be surrounded by some gurus in AI, gurus in technology who've kind of dedicated their careers to doing that. As I reminded them yesterday, I actually majored in artificial intelligence in college back in the 1900s. Yes, there are kids, there was AI in the 1900s, but unlike these guys, somehow I ended up going into the business world. So it's always nice to have people who actually do this for a living, as opposed to me, who read some books on it in the early 90s. So with no further delay, I want to kick off with Brian Dolan, whom I've known for the longest. I met Brian when he was part of a company that was going through the Cedars-Sinai Accelerator. Um, uh, Brian is a LA-based mathematician, inventor, cyberneticist. By the way, all this is written by AI. I felt that was appropriate, but it's real. With decades of experience building enterprise-grade AI products, many years of CXO experience with organizations like LabCorp, Fortrea, Yahoo, a company called MySpace that we're not going to talk any more about. So, Brian, in one sentence, not 10 sentences, one sentence, what's the most over-engineered thing people do when building healthcare AI models?
They over-engineer their process, the capital expenditure process. All AI projects are about process, and they over-engineer that process without thinking about innovation and backwards from product. That was like three sentences, and that was four. That was five.
See, you're over-engineering the process already here, but we're gonna come back to that, and I know we're gonna come back to that with our next panelist. So Noel Saldana, who is head of research analytics for the Rapid Deployment Studio at Fortrea, focusing on innovative solutions for clinical trials, research innovation. But she's been doing this in a number of organizations and a number of industries, so not just in healthcare. So we're bringing kind of a great tech perspective. So your one sentence kickoff question, Noel. What's one data reality from clinical research that most AI companies underestimate?
They underestimate how much of it is still manual in Excel spreadsheets and person to person and not recorded and easily consumable by AI technology. I did it one sentence until that.
We got process as well. So we got two like process answers going here. So we'll see how Alan does on this. But so Dr. Alan Young, physician, executive, AI strategist, who's been a leader in LA in the health tech community. He's worked with health systems, payers, digital health companies as chief medical officer of numerous organizations, but also a healthcare consultant at big firms like McKinsey and Deloitte and Accenture, but also more nimble kind of tech consulting firms like Point B and Slalom. Alan is much more at the downstream, the patient, the where AI meets patient care. And so, Alan, if you could remove one barrier that keeps AI from actually being adopted inside health systems, what would it be? Don't say process, please.
People in the process. So a roundabout way of saying a lot of times the people are looking for immediate impact or return on investment on these projects. And they found that it's really hard to attribute where return on investment is coming from with how complex healthcare is. And so I think that gets in the way of actually scaling and seeing real results over the long term, because people are short-sighted and saying, we need to make money, and to spend money, we need to justify we can make more money. So it kind of compounds and then prevents folks from, going through with the right processes to achieve the AI.
You said process.
Awesome. Yep, exactly.
I think the theme is going to be technology is easy, process is hard.
Right. But maybe we can use technology to work on the process. We're gonna get there, but I have a little anecdote on that, because the team met yesterday and we were kind of like reminding ourselves we probably have about 10 1-hour webinars of content and ideas right now. So we're gonna try to boil this down into one. And just this morning, I want to kick off talking about models and kind of theory versus reality, because all of you out there are probably playing around with models. You're using models. My story, fresh off of my reality this morning, I was on a conversation with a collaborator of mine in France, and we're working on some content, and we're using AI to help to construct this some marketing and some content around this. And this was ChatGPT. I shouldn't throw anyone under the bus, but I'm going to throw ChatGPT under the bus. So ChatGPT said, "Hey, Dave, this is great. Like, we've now built something. We've built this marketing message that is better than 90% of the healthcare marketing out there." And I was like, "That's pretty cool, but hey, ChatGPT, what would it take for us to be better than 99% of the healthcare marketing out there?" And ChatGPT said, "Dave, that's a great question, and you should know that you're already 80% there." And I was like, "What?" So this is models versus reality, right? And it's a very simple example. Imagine if you're trying to save lives or do research here. And so we're going to kick it off with Brian. And so again, a lot of these things look great in controlled environments or simple environments, although they can't even get, basic math right. But they really start to fall apart when you get into these massive sets of disorganized, heterogeneous data, clinical data and things like that. So help me through a little bit of what you've been doing to help rationalize and corral some of this data.
I think that in terms of the data side of things, everybody talks about the data being the problem, right? I don't feel like the data is the problem. I feel like it's the modeling and the use of the models. Like, how are we actually interacting with those models? When things like agentic control came along, that was pretty exciting, but it just exposes even more ridiculousness. I've been doing a lot of, quote unquote, vibe coding as an experiment over the past couple of weeks. And you find that the models themselves make and unmake the same decision multiple times. So if you go and you ask it the same question, it will say, "I'm going to remove this function from that particular process." From the data perspective, one thing that's underappreciated is that the people who are using these models have more data in their heads than their database does, right? They have much more domain knowledge. You can look up facts, but facts are not information, and information resides in the user's head. So one of the things that's exciting to me, we're talking about, we got to go, we already scraped the entire web. We're talking about, we're going to go collect all this data. Scale is going to make it. Scale is going to make it. We know that scale is not going to make it. What's exciting to me is the new generation of models that are coming out that rely on much, much less data and are able to integrate the knowledge and information that's contained in the user's heads already. We all went to school. We went and learned things, and those things are valuable. Sometimes they're wrong. But when you go and you check facts, you can say, okay, I was incorrect when I made this assumption that, Canada is the capital of France or whatever it is, which it took me forever. I can't believe it. I'm so embarrassed, by the way, especially when I was in Mexico. Anyway, so that the data aspect, I think, is kind of solved, honestly. And ETL is one of those things that's always going to be a pain in the butt. It will continue to be a pain in the butt. The agents will help make ETL and data loading and data normalization easier. It's the use of that, turning data into information that really resides sort of between the chair and the keyboard. And the models are not currently driving towards that. When you're working with ChatGPT this morning, it's not learning from anything you do. right? It's not really going back and forth. It's cutoff date, what, a year ago, whatever version you're using, and that's all it knows. But you understand the problem deeper, and you have no way of sort of forming it without like massive prompt engineering or sort of structured returns or other sort of MCP protocols. They only look at this database. So I don't feel like data really is the problem. I've never really run into a problem with not having enough data. I have a lot of problems with domain knowledge, and I have run into a lot of problems with lack of trust on domain knowledge. There are people that I've worked with in the past who are true experts who just can't convince the model that they know what they're talking about. So that's sort of a roundabout answer, as I am prone to do.
Yeah, no, I know, I like that, and I'm gonna pass the ball to Noel just to because you are building these models and bringing together massive amounts of data, as Brian said, but also very focused data that that Fortria, some of the other companies we've been working with are generating. How do you kind of make these models work with that universe of data and then the very focused data that might be that domain expertise Brian was talking about?
So I have some nuance to add on top of what Brian said when he's like, oh, like data is not the problem. Data might not be the problem. Sometimes the data is the problem, right? And so if it's not to say that data will never be the problem, because I've seen it swing the other direction as well. We're like, oh, well, now we have all these tools and technology is so great. I don't even have to worry about collecting the data properly anymore. ChatGPT will fix it for me. Like, data can't, or models can't just imagine things that are not there, right? If you're saying like, hey, I want to know the trend of what happened, but you've collected zero data on the trend that you want to know and you want it grounded in reality and you want something to go look at, I can't help you if that's not there, right? And one thing that Brian also mentioned is to be able to look back and challenge yourself. Be like, oh, I think I might have gotten it wrong. Is there something to look at? I don't add my own bias to the data, like as a scientist, but sometimes like this is what it tells you. It may or may not be counterintuitive. And if people still stare at it and say, no, 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 the data's still wrong, like I can't make it say anything different than what it says. This is what the data says. This is what the math says. I'm ethical and I'm not making it say what you want it to say just for the sake of making it say that. And so there are that's not life sciences specific. That is, I think, like all throughout my, near 2 decades in tech, have seen that over and over when something is really novel and counterintuitive, right? Um, I think the challenge is, so as you mentioned, like I've been in a bunch of different industries. For me, it's really understanding and partnering with the domain experts to understand the context with the data. Like, what is it trying, like, how are things originated? What was the intention of how to do this? What are we trying to do coming out of it that really shapes, and that's again true of all things, but specifically for me, like it is so nuanced. I think life sciences data is the most nuanced of the data that I've seen and requires the most like human expertise in interpreting it and understanding it of any of the data sets that I've seen before, right? Like in ad tech, like everyone knows what an ad is. It's really binary. Like, did you click on it or not in some cases? But, the amount of, you know, training it requires to look at some of the data sets that we're looking at is it's far outweighs what I had done previously. Again, I
Yeah.
think I've also roundabout answer to what
Right.
you
Well, and
asked.
it's a roundabout topic for sure. And again, you two are, I'll say you're taking it a little bit earlier in the process, and then you've got a physician like Alan. Alan, put on your physician hat for a moment, because as messy as all the data is that goes into those models, now when you are in front of a patient and trying to assess what's going on and trying to leverage this, hopefully you have new data, but I mean, do you ever have enough data, Alan, as a physician or as somebody from the operating side of a hospital?
And the answer is no, but I guess physicians in general, our workflow is trained to be kind of like decisive within ambiguity. And I say that because medical training teaches you a corpus of knowledge and you say, okay, now because of this training, I should be able to handle anything. And that's not true. Things are evolved. And what AI done is has highlighted the fact that physicians don't have all the data at their fingertips or on automatic recall. And so it's created this momentum in some places that how do we fill that gap? Can we use AI to like create and surface information, scan the entire electronic health record, record conversations using ambient AI, and then parse out information that's mostly relevant to the physician as they make a decision, diagnosis, decide on treatment. However, that's been received in different capacities to varying levels of acceptance. And so the answer is no, we don't have all the data. AI has been able to help fill some of those gaps. But as we said before, the process may not be designed to adopt this AI in a way that makes everyone feel comfortable. Because where's the other data coming from? I didn't know this about the patient. Is this really in the EHR? Do I need to trust it? What if it's an artifact or hallucination or something that then medical legally that physician says, well, the AI said this patient had this diagnosis. Turns out they name matched the wrong person with had the same name and same birth date and pulled in the wrong diagnosis, right? And could have been a pretty severe one. So a lot of like work to be done in that space.
Yeah, no, great point. And I think, and I'm definitely seeing some, cyclicality here because, of course, the work, and we're gonna make you put on some other hats throughout this, Alan. But so maybe you can walk away from being a physician now, and we'll get you into being a strategist soon. But as you think about this flow of um, research and developing drugs or developing treatments and testing them and then delivering them through physicians, and of course those same physicians are part of that initial development process and certainly the validation process. And so Noel, that's at least where you're spending time now, and want to kind of dig in a little bit more into this idea of talking about data and then data versus true evidence, and let's call it clinical grade evidence, right? Because ultimately if you are leading clinical trials that will ultimately determine if if a treatment makes sense, a drug makes sense, you've got to have real evidence. How do you bring that into this tech enabled world where there are hallucinations, where there is incomplete data, where maybe people don't even trust the process, and so they aren't even, playing ball with it? How do you think about that from a standpoint of a company like Fortrea or just the clinical trials world, broadly speaking?
So the pain point that Alan was bringing up, about like what do you know is real and what's not? I think this becomes a little bit of a product problem, actually, right? Like, how do you know to trust what you're looking at? Where does that trace back to? How was this created? Was this human curated? Was this AI generated? I think the more people have transparency into what is put in front of them and what traceability that there is, you'll be able to have that trust, right? And understand. Again, it's kind of also like, where is the capital of Canada? Clearly it's in France, right? Like you're like, where did it do this? How is it hallucinating? And in some places it's really easy to pick up those things when like clearly this is AI generated and clearly that's not reality. But some things, if you don't have any context at all, is so hard to discern. You're like, I don't know if this is real or not. And then that's where it gets really dangerous. That's because where it gets real pernicious. And so I think for me, it's thinking, not just about how do we make sure that the model is doing what we want it to do and the math is doing what we need it to do, but also like, where do these results end up going? What are the decisions that people make with those models? How delicate are each of those decisions and how accurate? And this is not just, again, like not just in this context, but in general, like what is understanding what the risk is for each of those models that you're generating? Like, what is the decision, right? Like if you imagine what our company does, it's everything, like in the operational side. And so some of those things are about like, how do we make the process faster? Right? Like, what is the decision that we're making? Is it just about big quotes around, is it just about eliminating human toil, right? Like, can we make a decision faster? Like, are we allowing us to supercharge all the humans who are in the process. And so much of this is manual and judgment. Like, are we enabling them to sort through things faster? Can we do that? Right. And so that's where, and not every AI use case is about efficacy, right? And when the case is like, if it's about like the efficacy of a drug or the things that are really needed to report like safety, et cetera, like all of the things that have governance around them, like I think there's very stringent processes to making sure that the data that goes into there is really, really solid. And so I don't think that there's so much overlap, just from my point of view, in terms of like what you may just let the machines and robots take over when it comes to healthcare and reporting whether or not like you're killing people or not, right? Like there is ultimately like ground truth that I think will be made, that is core to a lot of the things that will be needed and necessary to understand things like efficacy and safety.
Yeah, no, that's a good point. And one of the things that you mentioned there, is some really good points, but just this idea of sort of scale and removing some of the toil. And I'm going to put in a plug for Terasaki Institute, because there's a tremendous amount of automation going on in a relatively small research institute, but there's some pretty incredible, scalable technologies and, organs on a chip and, of course, just your standard, lab automation. But, where things are starting to go now, even before clinical trials into the, back in the, upstream, research and development side of things are, building models to test things earlier, more and more rapidly, in parallel mode. And, I know some of that is kind of work that, Fortria is supporting, kind of the follow-on piece. But Brian, I want to dig a little bit into some of the stuff you've been thinking about, how do you leverage technology like this, in drug discovery, or maybe not even drug discovery, what comes before drug discovery? How do you accelerate results and reduce some of that toil that Noel is talking about?
Yeah, I think it's, you say it as a technology, and to tie together what you said and what Noel said, like one of the things I like to say all the time is AI is a technology and not a product. And to draw that distinguish between those two, a product solves a gap in the user experience. Like I need a thing and this makes a thing. I need my food to not spoil. And a technology is something like electricity that powers a refrigerator so your food doesn't spoil, right? So AI can power a lot of these things, but it is not the product. And I think a lot of the problem is with a lot of the technologies that come along, you have the technologist voice is too strong. So the technologist gets to say, hey, I have this new technology. It can do anything in the world. And they have too much, especially in the modern sort of startup view of the world, they have too much influence over how it gets used, right? So when we talk about products and we talk about how can we use this technology to accelerate products? Well, what is the product that we're talking about in drug discovery? We want to really, really, when you think about it, the thing we need to accomplish in drug discovery is new ideas and new hypotheses, because the search space is so vast. It's so vast that we can't just say, hey, what if I, took this protein and that protein and combined them? We can't keep doing that. That's what we've been doing for decades now. Just these sort of small bench experiments. So the AI is really there to help create hypotheses. So the product itself is a hypothesis generator. Maybe we can, maybe it will fold this way, maybe it will fold that way. And there's a lot of things in that tool chain, a lot of technologies in that tool chain that are pretty interesting and are just now, in my opinion, just now beginning to kind of come together. And I see it on a continuum of, quantum computing, all these protein interactions, these are all quantum, they're natural processes, they're naturally quantum phenomenon, right? So quantum computing is beginning to get away from the sort of bits and bytes view of the world, and how do we actually model a problem with not just binary answers, right? So quantum computing, AI is is a part of that stack, that technology stack right there in the middle. So the quantum machine can help us figure out what would this protein look like if we manufactured it. And the AI can postulate a new one. So already there, we have that back and forth on like, what's the new possible? And then, of course, manufacturing, it's an important part of what's going to happen in synthetic biology and the cell-free systems and the cellular systems and gene therapies. All of those are all places where we need to discover new modalities. I was at a great seminar yesterday talking about like how do you manufacture a lot of these new precision medicines? How do you stabilize them? How do you ship them? So AI in itself as a technology can accelerate each one of those, even including the centerpiece. But the product itself is the idea that allows us to develop a hypothesis and send it through the pipeline. When we're talking about the early drug discovery, delivery, testing, trials, similar story. But I think the really interesting piece right there is going from the quantum into the synth bio, and AI is sort of a substrate for all of that, just to get us to the point where we can find efficacy.
Yeah, no, interesting. And I think one of the things you're saying, which I think is a good point, is that you made the point. AI is not not the product. It's this technology, and again, it's this enabler. And I think there might be somebody listening in here who's too young, but I think we've all been through the dot com era, right? And there was a time in the 90s when we were all doing whatever our businesses were, accounting or medicine or selling pet food or whatever. And then there was a year when we were all doing accounting and medicine and selling pet food with a .com at the end, right? And we
Right.
were suddenly it was like these internet businesses, and then a few years passed, and suddenly nobody talks about internet businesses because every business uses the internet, just like nobody talks about telephone businesses anymore. We've
Right.
all kind of fully adopted the telephone and now stopped using it, by the way. But
You
so
don't have to
now
even,
AI becomes the next thing, right? I mean,
right.
there are AI businesses right now, but some of them are just the same companies that put a .ai on their domain name, the same way they put a .com, 25 years ago, and we'll get past that, and then it'll just be AI is the status quo, and again, it's an enabling technology, and it's probably you might like this analogy, Brian, because people in the medical world are always talking about cancer. It's like we have to stop talking about like it's not a cancer. It's like cancer is this family, and Alan's going to correct me on this, but like there are so many nuances to what cancers are that are impacting people. So AI is kind of like a cancer in in that it's not one thing. It's this whole overlapping array of things, and we want to leverage it in a good way, not a bad way. So that's my soundbite for this morning: is AI is a cancer. So
I would say, Dave, just one quick thing, because I'm old, right? We don't have to go back as far as the .coms. We can go back to blockchain, metaverse, chatbots. I mean, like the last 10 years have shown a bunch of these trends that have come through, and some have proven to have residual value. Most of them is washed out. I don't think AI is like that. I think AI is extremely powerful, but it's simultaneously in a quantum state. It's Schrodinger's technology, right? It's simultaneously much more powerful than we're using it for, and much less efficient at what we think we want to use it for. Like our expectations of it are almost 180 reverse. Anyway.
yeah,
My
yeah.
favorite of all of those trends was when everything was a social network. It's like pet food also now has a social network, and it's a
Right.
social network in your app, your mobile
Right.
app.
Is your dog food social?
Go talk to your friends about your dog food.
She is not kidding. We
I'm
lived
not
through
kidding.
that.
Yeah, no, it is true. It is true. I somewhere in here, I have a pets.com puppet even. So I'll break it out for the next webinar. But so Alan, this actually is a good time to bring it back, because you did talk about physicians making decisions with a lot of uncertainty. And so first of all, maybe just looking at what we're talking about here, are is the state of AI right now, is it bringing more clarity, or is it actually maybe introducing more uncertainty, like more ideas, but also more uncertainty into the clinical decision process?
Yeah, great question. I think it's twofold, and it's a double-edged sword right now in the kind of clinical applications of AI. I'll use kind of the most shiny and most kind of prevalent example around using ambient AI to assist with documentation,
Mm-hmm.
or even using generative AI to create summary notes, for patients, either admission or discharge or whatnot. And this has been touted to really, decrease kind of the administrative burden on providers, which I think is true. However, it's also accelerated and increased the volume of data that providers are now responsible for. So it used to be I could write a really quick rounding note on a patient in paper and pen, and no nurse would ever come and say, or administrator would say, "Oh, that's inappropriate. You left like a bunch of acronyms and we're supposed to discharge the patient now." Fast forward, now we have this like volume of information that needs to be captured to dot all the I's and cross all the T's to meet regulatory, billing, compliance, patient safety, quality, all of these different requirements that the AI is going to help us with. But one of the unfortunate byproducts of this is what I'd call cognitive offloading, where clinicians are now just relying on the AI, and more they use it, it becomes, there's a bias, right? Like, okay, I'm using it. No one's told me it's wrong, so I'm just going to assume it's right. And as you do that over time, just like we trust Google and we trust, Meta or social media that, oh, they don't make that many mistakes, you just use it on a day-to-day basis. And I think what's happening is we're seeing the impact of this cognitive offloading in these, bright, articulate, really critical thinking providers suddenly relying on the AI to do stuff, and their cognitive functionality or performance goes down. And there's numerous journal articles that have cited this, and looking at places that have relied on, someone AI sending my emails, AI summarizing my notes, AI writing my documentation. The lack of that use of that part of the brain has an effect over time. And I think that's the double-edged sword. As physicians and providers use AI, they'll see the benefits, but there's also downsides that no one really talks about as much. There's some people in different corners screaming it loudly, but it's kind of falling on deaf ears.
Yeah, no, and I think that's a really interesting point. And I even, not even from a, practicing medicine standpoint, just in terms of, doing research or doing work, it's like, I want to make sure I'm not using it in that way too much. And, I think where we want to go, and where, technology is certainly going is, right now we've got a tool where you can put a question in and get an answer. And again, I was talking to somebody this morning, and it was like, I will still pick up my phone and go to Safari and tap in the address bar and type in a question that will then, get a Google response. Like I'll still do that 50 times a day because I'm old. And then my teenage son, picks up his phone, opens up ChatGPT, and asks it a question verbally, and like that's how he's getting the answer, right? So like people are adapting that way. But I think where we want to go, and this is where physicians should want to go, it's where researchers should want to go, it's where any of us just on the business side of things should want to go, is it's not about put a question in and get an answer and then take that answer and ship it off to whoever asked you for it. It's about, let's have this as a colleague that we can have a conversation with. Let's have it as something where we can have a back and forth, and the AI tool is making us smarter and stronger, and then in turn our feedback is making the AI tool smarter and stronger. But there's definitely this back and forth that and I imagine some of that's going on in the in hospitals, and even some of the scribes and things like that. It's not just about capturing the information, but it's about creating a little bit of a dialogue. And I mean, do you see that happening on the healthcare side, Alan?
I see it happening at the institutions that have the infrastructure and the in-house talent to recognize the pitfalls of AI, and they're building the constructs around, ethical AI and reliable AI and kind of compliant AI. And they're deploying it in a way, and doing actually randomized controlled studies within their organization to demonstrate where there's these pitfalls. And so that is created awareness, I think, but they are a small fraction of the organizations that are out there that are clamoring and buying and experimenting with AI, who are doing it in a vacuum where there's no real experience and no real process in place or infrastructure in place to really guide. Putting together an AI steering committee sounds great as a first step, but if no one on your steering committee knows what they're doing, then it's not going to really guide the ship in the right direction. So there's a lot of, I think, room for better understanding of this process on the healthcare side. And unfortunately, given where healthcare has been this year and where there's challenges across the industry, I don't see this being a high priority at 80 to 90% of the organizations that are just struggling to pay the bills, keep their patients alive, and keep their nurses and doctors gainfully employed. I just talked to a physician leader somewhere on the West Coast, and he couldn't meet with me because the providers went on strike. And I can only think of the reasons physicians and nurses are going on strike nowadays, but this is happening. Like, it's really a challenge to the entire industry. And this idea of talking about AI in a vacuum and thinking, oh, AI is going to solve problems. I think there's 95% of other problems that don't need AI. They just need actual, like, people to roll up their sleeves and fix them.
Yeah. Although I will say, so far, AI doesn't go on strike, right? So, so
Are you
far.
sure? Are you sure? Are you sure those outages that cause things to come down isn't just the AI going on strike? Just saying.
That's a good point. When it tells me I've asked the same question too many times and I have to, like, cool off until it's like
Just
that means
saying.
it's helping somebody else, like that whatever that movie was, Her, right? Was that it's like,
Yeah.
are you talking to other people at the same time? Like, thought it was just me. But Alan, you mentioned kind of like AI steering committees and kind of like this top level AI strategy, and I want to get into a bit of both regulatory and funding in a couple of minutes. So it'll take it back to a little bit of what that panel I was doing earlier in the year. But Brian, kind of AI steering committees and kind of this top level AI strategy. I mean, you've spent some time recently with two massive organizations that existed long before there was AI in practice, and now there's a chief AI officer, and there's this and that. What are these large companies doing to move into this world? What are they doing right, and what are they still not doing right?
Yeah. Well, if we go back to just the question, what are they doing? The answer to that is thrash, right? They're trying to figure it out just like everybody else is. I mean, like they're thrashing a million different ways. Um, again, I said the technologists have too big of a voice in these things. And I don't really consider myself a technologist. I'm more of an analyst, but these AI steering committees are like often driven by the technologists because people believe you have to understand how, what's going on under the hood of the computer to understand AI. But if we can flip that script and say, listen, AI is a product and this is what we need to get out of it, then you can stop having these honestly ridiculous conversations about, like, can we just throw AI at it? Can we, let's get some AI in here and make it work. It's like, those are ridiculous conversations. I've been in more than one of those, over the course of my career. And so if we can get to that point, like, what does the business need to accomplish? I mean, this is one of the things, somebody comes to you and says, what's your AI strategy? It's like, well, what's my electricity strategy? Right? Like, if I have a manual coal-powered factory, what's my electricity strategy? Oh, go in and plug things in that can be plugged in. Like, that's really all it is. There's not like, there's not much more to do when you start thinking about what is your AI strategy. So it's an overblown thing. I don't really want to, I feel like I'm pointing fingers, and I kind of am. But really, it's because people don't know what to do, and they're turning to the technologists who are not analysts, who are not business users, to say, what should I be doing? And of course, if you ask me, even as an analyst or a technologist, what should you be doing right now? Buying a quantum computer, of course. Buying bigger machines, of course. Like, what else? Really, I should be going, hey, where are the problems that are applicable to be, approachable, amenable to AI? And let's work towards those. And they're not what you think they are. It's, everybody wants to do a chatbot for the patient. Great. Reduce the patient experience and hallucinate? I don't think so. The MIT study, and 95% of AI projects fail. They fail for the exact same reasons that other projects fail. And a lot of times that is because it wasn't a very good problem to begin with. It was just a pilot. Like, you had no in one of my roles, I was approached by startups and like, we want to do a pilot with you. It's like, I don't want 1,000 pilots lying or dead around my organization just so we can have AI in here. I want to find legit problems that you can solve. So that to me, the AI steering committee has to be driven by business value, encouraged and inflamed and incited and inspired by the technologists who can't wait to get a bigger machine.
Yeah.
But it has to be driven by business value. And that's not what happens, because I think people get intimidated when somebody with like my background says, no, 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 we got to go buy 1,000 GPUs. Yeah, that's not really, that doesn't provide business value. What we really have to do is reduce toil. What we really have to do is increase operational efficiency. What we really have to do is make our employees happier. So that to me is why where the corporate governance kind of falls apart, is they're so excited by the tech that they forget to think that they still have to run a business. It doesn't have to be boring and mundane. It could glow blue. Oh, man, I didn't sleep last night. It can glow blue. It can be exciting. It can have holograms, whatever you want, but it still has to.
Got it. No, that's good insight, and I am gonna take this into the regulatory space, which we talked about yesterday, and we got a question on that. But there's another question that came in from the audience that I want to see if we can tackle first, which is from Tom Jang, and this is a little bit for Noel and Alan, I think. So they're developing an AI model for predicting acute rejection in kidney transplantation. And so, the question is, what specific explainability or clinical validation evidence do you need to see before you'd feel comfortable letting an AI score influence your treatment decision at the bedside? So that's kind of an Alan question, but I want to take it into Noel's world for a moment because, how do you leverage, the clinical trials process to help validate this kind of model before you would even put it into the hands of Alan and his colleagues?
I'm so curious how Alan would answer this. Like, I don't have, like, I'm so far in
That's
the
why I want you to answer
operational
first, because
space
your job comes first. Alan's not even using this technology until you've made sure that he can legally do it. So
That's fair. So this question specifically asking around specific models, I guess that's why I'm like, well, it depends, right? Like I think as a, first and foremost as a scientist, right? Like you have, like for me as like a data scientist, you have these metrics that to judge whether or not a model is good, right? Like so if you're going to pick something like an AUC score, that is, classic kind of metric, and there are thresholds that and Brian and I have worked together in various contexts, and like the AUC, that's acceptable for whether or not you should click on an ad, or people who should serve someone ad versus like, is this vaccine effective? Very different. There are very different thresholds that you would pick, and there's industry standards for those things. And I think the more common a metric is used, the more things that are out there in the literature and the industry that will say like, this is why you should trust this. Like I'm not just picking some obscure threshold and some model that I just came up with and no one's seen before, right? Like there's all these like peer-reviewed articles that will say like there's a whole community of people who like use the same math, right? So I think we have a lot of benchmarks that we can use, and we can bring those. And when we have those conversations with the end users, like, why did you pick this model, right? Like, and I think if you have enough research that you've done, if you've done your homework, right? If you're not just being an alpha nerd to pick something because you want to and it's cool and it's shiny and gave you an excuse to buy a quantum computer, right? Like if you go in there and saying like, this is why we've done this, and here, here's the industries, and this is best practice, and this is also bleeding edge research that has shown like this is acceptable, and these are the results. But you don't necessarily make a recommendation. Like I wouldn't make a recommendation to Alan, to Dr. Young, to say, and I think the decision you should make is this, right? Like I can say, let me tell you exactly how this model was built. Let me also be really transparent around the assumptions, around the data that was put into it, what was labeled as good or bad, who labeled those things if I can, like how we did test and training on those things, and and we always have to weigh, in research, which algorithms we're picking for explainability as well. Like, is this something that is really intuitive or is this a complete black box in terms of the models that you're picking? You might have a black box that gives you really cool and accurate results, but you can't really explain how it did it. It's a little bit of magic. And those things are, obviously have a little less trust. But for some use cases, that's great. Like you don't really need to know how it works. It automatically created a map for me. That's cool, right? Like if it's just generating like cool pictures, but like that's different than like a decision that you would bring to a clinician.
Yeah. So Alan, now the decision's in the clinician's hands, and I like that idea of like, yeah, do you even need to know how it works, right? It's you want to trust it, but you need to know how it works, and how do you take a new technology and start to make decisions at the bedside?
Yeah, I'll focus on three areas. I think Noel touched on a few of them: trust, credibility, and outcomes. I think being credible is meaning that you can, in the provider's eyes, come from a place that they respect, a peer, having literature that's been published or doing things that in their realm is considered like to meet the standards of medical care. Trust is you could have credibility. You could be a huge AI company, a tech company, right? Epic EHR company, but trust is a different thing, because once you lose that first chance to build trust, it's very difficult to regain. So if physicians are piloting something and it fails in the middle of the pilot or creates problems you have to go and solve, or patients are hurt, then you probably have eroded the trust, even though you came in as a credible, partner technology. The other thing is aligning on outcomes, and I think this is a little harder for most companies that are coming in and kind of saying, hey, we can really fix this problem that you have. Very often, those tech companies fail to really kind of unwrap that problem and understand what it really means for patients and physicians. And so in this case, are you looking to improve readmission rate? Are you looking to decrease transplant rejection? Are you looking to decrease costs? There's all different that folks are evaluating. You go to a provider, I'll put on linear physicians working thirds and do in this field. They really care about that patients will get better, go home, and not come back. Colleagues in the nephrology world and transplant world is considered like best practice, right? I think those are the two driving forces. Obviously, there's now nuance to that, but in general, sometimes AI companies come in and fail to see that and then don't really adhere to specialty guidelines and previous practice. They come and say, oh, you guys are not doing well, so this is how you fix it. And they don't realize that maybe this has been done before or tried before, experimented with before. And then also, if you're just trying to save money and cut costs, it's probably not going to resonate well with physicians and patients who are looking not for health systems to cut costs and give them, cheaper care. They want the best possible outcomes for them and their family.
So Ben, again, back to this idea that this is just another tool in the toolkit, and so this is not necessarily reinventing healthcare as much as it's just if it can get people to better outcomes, as you said, which the stethoscope can get to better outcomes. Let's use a stethoscope. AI can get to better outcomes. Let's use AI, right? It's all about that end goal. We don't have a ton of time to talk about this, and I left it to the end because one, it could it's a stressful area, but the regulatory landscape right now, coupled with the funding landscape, is challenging, and so rather than asking about where the regulatory environment is slowing things down, or like let's not focus on where the regulatory constraints are saying no. I would love to get a sense of where is the regulatory landscape opening up possibilities here. And Brian, I think you and I worked on an ARPA H proposal a while back, which is an organization that's trying to find ways to say yes. Where do you see kind of whether it's the government itself or just the overall sort of regulatory landscape, government and otherwise, opening the door to new innovations here?
Well, I mean, it's hard to be optimistic right now. And I'm not going to shy away from it.
I know, but and it's always hard for you to be optimistic. But
No, no, that's not true. You know that to be done. It's just I think we're in an anti-science environment, right? And unfortunately, the federal government and the FDA in particular being run by people who don't understand or believe in science. So that's bad. I think we can unequivocally say that this is not good for our industry. In addition, coupling that with the economics of our industry right now, it's really, really tough. However, you can try to be optimistic and say, well, with the collapse of a lot of our systems and the collapse of faith in science, that's going to open up new opportunities. So we have an opportunity to rewrite some of the historical regulations that were really bad, right? Like really bad ideas. I think Jason Kelly from Ginkgo, if that's his name, if I have it right, he likes to say like he likes to say that the FDA is the only industry that got it right on genetic engineering. Like the agriculture department, USDA was like, if you genetically modify something, that process is regulated, but the FDA is like, we don't care, it's just the outcome. That hasn't really propagated with new technologies like AI as a technology. Does the FDA really need to regulate it? Does the NIH really need to regulate it? And they have been. They've been saying we're not sure about AI-generated results. As long as you can prove your results at the end of the day, who cares how it was generated, right? And AI is just math, right? It's the same thing. You look at it's the exact same matrix transformations, just put in a different order as was support vector machines, which have been approved, or even decision trees, which have been approved. Like all the mathematics are just the same. Traditional statistics, everybody who's a scientist believes traditional statistics, same math, right? Iterated, reweighted least squares, weighted least squares. It's the same math as a transformer, right? So it's silly to kind of go in and say the FDA say we're regulating AI things differently. They should be looking at the outcomes. And maybe that'll get unpacked a little bit. Maybe in this sort of burning down of the house, we'll be able to come back and say, let's have a more reasonable approach to the technologies that are getting us to those solutions. But, we got a little bit of time before we're going to be able to rebuild in a reasonable way.
Yeah, got it. Noel, how do you take that sort of the regulatory side and a bit of the funding and support angle as well?
Oh gosh. I think for me, the regulatory side, I've seen a lot of reaction. So I deal with it most when it comes to like what data can we use, or what data can we or can we not even track when it comes or keep, and how we store it, et cetera.
Yeah, and by the way, just sorry to interrupt, but like as you say that, I mean, it's not just a regulatory question. It's it's an ethics question, right? I mean,
Sure.
there's an element of ethics and privacy and
Yeah.
in all of this.
Yeah. And my gut reaction to this is that I've seen people be so scared of it that they overcorrect for those things. And that
Yeah.
becomes incredibly limiting when people do that, right? Like, oh, when, GDPR came a thing like, therefore, we have to anonymize all data. We can't know any person whatsoever at all. Like, how are we going to track fraud then, guys? As an example, like if we don't know who's doing it, like this actually becomes dangerous. And so like that quick anecdote is the types of things that when I think about regulatory and what we do, I'm like, how do we balance this thing, as you said, like how do we balance ethics, and we want to do right by people. And I've always said that, AI and data science kind of ride this line between being creepy and being really cool. Right. And like we always want to make sure that we're not on the side of being creepy. And especially like it's so delicate as we work with, with humans. But I just want one thought to leave you with is, I don't want the AI to be just completely untrusted, or the data to be like untrusted at all, to the fact that we're going to miss out on the innovation. Right. We want to have guardrails in place, sure, so we're not all creepy. But at the same time, we want to be able to we don't want to have, again, with like Brian was talking about, committees and stuff. You'll see like if you have people who are so on those sorts of committees who are so stringent in the rules, and they take it to you're going to just cut off all the innovation. Like we cannot store any data. We cannot trust these things. Like in order for us to maintain compliant, we must do all of these things. And you're like, well, that means I have no data and I have no tools, and therefore I can't innovate on anything. Right.
Yeah.
And that's when it comes to like, from my point of view, like where my struggle is, right? Like to do the best with saying like, this is my intention of how, we remain ethical and we do right by, the people and the patients, et cetera. but we're not trying to do anything nefarious, like it's some of those things seem open to interpretation, but to just keep pushing to say like it doesn't have to be that extreme. Like we don't need to have such a chokehold on these things for people who haven't, necessarily been in data. Like they just see a rule and they're like, all right, I got to follow it. This is the only way we can follow it.
Yeah, no, I love that. You're like leading into I think it's the final piece of that question. Back to Alan. From the provider side, and maybe it's as simple as saying like is the Hippocratic Oath embedded as a core core rule in an AI model, or how do you make sure you are maintaining that same level that physicians have done for eons, but as kind of Noelle is saying, without being overly restrictive.
Yeah, no, I think it kind of akins to the practice of medicine is an art form driven by science, right? So if you think about the dichotomy of that, it's like we're not going and saying, we learned this, therefore this, and there is an art to it in terms of interpreting the data, talking to the patient, doing an exam, right? So I think where AI can really drive that is that it leaves the interpretation or the ultimate decision on that holistic view. And I think if we can continue to use AI in a meaningful way to drive in the objective data that needs to be captured and do it in a workflow or a process that is efficient and doesn't interrupt the existing workflows too much, then I think you'll see gradual and consistent adoption over time. I think if you go in with too dramatic claims of great overperformance or ROI or whatever, you're going to lose a lot of clinicians. And again, they have other things that are a priority. Even if your CFO and CTO and CIO are telling you, oh yeah, we got to do AI, I think that, the COO, CMO and others would be, and CNO will be like, you know what, like we're not even going to want to go down this path right now. So you're going to see organizations internally having these conflicts. But I think if you treat it like an art within and confine it within the science, then I think it'll be better adopted.
Yeah, no, that's a great. I think it's a great kind of like it's a good closing thought. It opens up a lot of ideas because so this will be a part two. We'll talk about 2026, but just the idea of you just mentioned five other job functions in in hospitals that also need to be part of this decision making process before any of this gets implemented. And there's additional legal issues, and there's a question that we're not going to touch on now, but in terms of responsibility and the same sort of thing, it's like who owns a decision, who owns a piece of content, and whether it's generated by a human or AI. There's a lot behind that. So I would love to see a part two. So this is Maurizio. We're talk to Stuart. We're going to work on. We're going to work on the next one, maybe in person at Terasaki, because we owe Brian coffee in Woodland Hills. So and we're happy to get coffee for Alan and Noelle too. So with that, Alan, Noelle, Brian, thank you so much for joining me here this morning. Maurizio, thanks for having all of us. A lot more to talk about, and again, I think 2026 is going to be a big year for all that we're talking about, and some of this getting implemented more at the research level, at the validation level, at the clinical trials, and then into the delivery of care. So there's a lot more to come, and please reach out to all of these individuals if they can be helpful with what you're doing, and I know they can to Terasaki and the community. So with that, I think we're good to send people off for happy holidays and happy New Year, Maurizio, right?
Absolutely. And again, thank you to all of you for making yourself available, and to our audience for tuning in. And happy holidays to everybody. And there's no question these topics should be picked up into the new year. So we look forward to having everybody back.
Awesome. Thank you all. Take care.